I thank Mary Mullen, who put this together to bring us together. About 6 or 7 years ago, I was in San Diego for a heart conference, and a physician named Pete Marwick was actually speaking about imaging in the heart. And I walked into the presentation, and the way these presentations are, there are about 100 going on at the San Diego Convention Center at the same time. And it happened to be talking about imaging the heart in patients with breast cancer. And Pete Marwick talked about how there are some new ways of following heart function in breast cancer, because we know that a lot of the medicines that we were giving to women with breast cancer, it was curing their cancer, but they were dying of heart failure. In fact, 5 years ago, we would have probably said that a woman with stage 2A or 2B breast cancer was more likely to die of heart failure than her cancer. And that was unheard of. 20, 30 years ago, people were just dying of breast cancer. And I really took this to heart when I came back to Pittsburgh, and I wanted to get interested in this. And in the last 6 or 7 years, this new field has cropped up called cardio-oncology. And I'm very proud of our group at Shadyside, where Josh Levinson, my partner, has really taken up the mantra of leading cardio-oncology. And we are in touch with a lot of the leaders around the country that do this work. And so whenever there's something new, we actually have cutting edge information as to what's happening. You'll see as we talk a little bit that most every cancer drug that we give, even non-drugs that we give, affect the heart. Radiation affects the heart. Everything really does affect the heart in one way or another. And I'll go through some of that with you. Are my slides advancing? Did they go up? Yes, good. So let me give you some basic facts. If you go back to 1970, there were only 3 million survivors of cancer in the United States. We're up to 17 million right now. And that's not because we have a bigger population, it's just because we're better at treating this, right? I mean, we have all these new drugs that really prolonged life with cancer. And most cancer survivors do not receive appropriate primary and oncologic services. And that's a pretty strong statement. But, when people come into my office, I don't just look at their heart and their ejection fraction. I ask them how they're feeling in general. I ask them some of the questions you would ask, Wendy, about how their spirits are. I also ask them a little bit about everything else going on in their lives, because as you'll see, cancer affects your life in many, many different ways. The needs include screening cancer patients, right? When you go into remission with cancer, you still have to be screened, because one of the most common things that happens is another cancer comes up or something else comes up, and that's a real issue. You have to know when to intervene. You have to know when to give psychological support. And cancer therapy is a lot of comorbid conditions. So we need to keep those in mind. So communication and coordination of care is very, very critical. And there are very few, I don't know that we do a great job of that all the time, coordinating care. I work very closely with our oncologists at Hillman, but I just saw 25 patients today. And I've got 25 lives I touched today, and now I'm talking with you, and after that I'll get on and do all my messages. It's very easy for somebody to fall through the cracks and not make them feel important. But when you're in that office with me for that 20 minutes or whatever it is, you're the most important person in the world. And it's a challenge to coordinate that care. Let me give you some common facts. When we talk about 17 million cancer survivors, in women, it's 44% of those women have breast cancer, 9% have uterine, 9% have colon cancer, 8% are thyroid cancer survivors, and 8% are melanoma survivors. But the biggest cohort clearly is breast cancer for women. For men, prostate cancer is probably the number one thing that happens to men, and 45% of men have prostate cancer. I just met a man today who has metastatic prostate cancer to bone, and he was given a new drug called Erleada. Men get hormone therapy, right, when they get prostate cancer. So it totally changes your body, your life, your feeling, and this person's getting Erleada, which has definitely lowered his PSA. PSA is a test we do on patients with prostate cancer to measure how active the disease is. It lowered his PSA to 0, which is amazing. But there are side effects that go along with that. Colon cancer only accounts for 10%. Then we have melanoma, bladder cancer, and the lymphomas or the hematologic malignancies that account for 5%. So clearly, of those 17 million survivors, breast cancer and prostate cancer are the two biggest, okay, for women and for men. And what are the frequency and risks of subsequent cancers? Well, when you give somebody chemotherapy, you're hitting the actual DNA of the cells. And so it's very easy to imagine that somebody who's been affected by that nuclear explosion in their genetic material may develop another type of mutation, if you will. When we were living through mutations with COVID right now, right? Where the virus is mutating all the time. Well, that happens in cancer cells too, and different cancers develop. I talked a little bit about radiation. Well, radiation affects the heart in many ways. For young kids that used to have Hodgkin's disease and they got mantle radiation on their chest, 20 years later, we're seeing constrictive pericarditis or pericardial disease, coronary disease in 20 and 30-year-old kids that got cancer radiation therapy as children. Women who had breast cancer on the left side and got radiation years ago on the left are, again, 20 years down the road, there's a latency period, have cardiovascular disease down the road. We're better at radiation today than we were 20, 30 years ago. So now we give localized radiation to the breast. We also do prone radiation, where on some centers have women actually laying on their stomach and the breast hangs down and they just radiate the breast from the side, not to hit the chest wall cavity, the lungs, the heart, and the other organs. So you can imagine that all these things that we do to people truly affect them. Lifestyle is important too. And let's face it, when you have an unhealthy lifestyle, not everybody, lives in a clean environment. And when you have cancer and you're in a less than clean environment and you have a PICC line or you have some other things, these lines get infected. That ultimately leads to infections of heart valves. It's terrible. And then some people have genetic predispositions to cancer. We have to keep those in mind as well. Male cancer survivors, I told you 45%. The likelihood of mortality from a secondary primary cancer is 45%. So yeah, you treated that colon cancer, they get a secondary cancer, either from the chemotherapy or just spontaneously occurs. For women, it's 33%. You may treat that primary cancer in a woman, but once they've been exposed to cancer therapy, there's a 33% chance that they may succumb to a second cancer. And I'm not doing this to depress anybody in the audience. What I'm doing is to point out to you how complex you all are and how it's very important to have somebody who understands all that that's in your corner. So what do I do as a cardiologist? Well, how do I monitor cancer patients? Well, I need to know what drugs they're on. And I'll be perfectly honest, there are more cancer drugs developed every day than I can keep track of. And sometimes I am and have to resort to the internet to check on the latest drug that's been developed so I can figure out what the side effects are. And I have to do it by class, right? So if I know that some of the hormone-related drugs that were affecting prostate cancer caused coronary disease or hypertension, the new drug that is a similar cousin, which we don't have a lot of data on, may probably do the same thing. So that's what I have to look for. There are neurologic issues with chemotherapy. Chemotherapy induces neuropathy. So some people get numbness and tingling. Some drugs affect hearing. There are gynecologic issues. I mean, for young women that have cancers, there's infertility in pregnancy. Women want to have kids, and those things happen. I talked a little bit about infections, but what about bone health? Osteoporosis is a big deal in patients with cancer. And by the way, full disclosure here, I had a bone scan and I have osteopenia. So men get this stuff too. And I just finished my course of vitamin D and I'm taking a little calcium and don't think it's just a disease of women. And by the way, doctors get sick and they crap on the same pot that you all do. And we have the same problems that you all do. Don't think that we all of a sudden don't have anything. Osteopenia. I mean, so all this stuff happens. And you know what? Depression is a big part of that. And that's where Wendy and her group come in to help, because just like the guy I told you about that I met earlier today that had a heart attack, he's got a wife at home with cancer of the lung. He's resorting to smoking. He's not taking care of his sleep apnea. He's overweight. Yeah, he came in to me to check his heart, but there's all this other stuff that's affecting his heart, right? And I have to keep that in mind. So there's depression, there's anxiety, there's fatigue, there's cognitive limitations. I don't know how some people function in a business or working on full-time jobs dealing with all this stuff. I have trouble just dealing with my full-time job, and I'm blessed not to deal with this other stuff. I just don't know how some people do it. You then have sleep problems, and when you don't sleep well, you're an irritant to your family. Your family's just trying to take care of you. You're snapping at them. You can imagine those interactions. And then there's sexual dysfunction. And for women, there's pain on sex. And so then women start feeling guilty that they can't please their man, or men start feeling guilty that they don't want to try to take advantage of their partner when their partner is ill. I mean, all this stuff comes in, right? And then you add on top of this pain meds. People start taking opioids. And before you know it, you have people that are dependent on these drugs. Another, necessary evil, these opioids, but certainly not good. And then there's the part that nobody really talks about, and I don't think a lot of doctors we do realize, but we just don't pay enough attention to it. Cancer destroys your bank, your wallet, right? I mean, 25% of cancer survivors reported that they used up all or most of their savings in the process of cancer treatment. 10% of cancer survivors are unable to pay for basic necessities like food, heat, housing, while 8% delayed or avoided cancer care due to costs. I just had a patient today that stopped a drug that could avoid a stroke because she can't afford the drug. I still have to deal with that. I'm not sure what we're going to do except give Coumadin, which is cheaper, but I'll figure that out later tonight. A study suggested that cancer survivors under 65 years of age are more likely to forego medical care due to cost compared to older individuals, and that's only because of Medicare, right? But now that I am a Medicare participant, I can tell you it does not cover everything. Although I'm still working, so I have other health insurance. I have looked at this. Medicare does not cover everything. In fact, it's bill after bill after bill. So there's a big social safety net that we're missing in this country. So why a cardiologist? Why am I here? Good question. Because everything that you do in cancer therapy, on one way or another, affects the heart. I talked about radiation for breast cancer, non-small cell lung cancer, or lung cancer, head and neck cancer. If you've ever seen patients that have gotten this, they get radiated. But again, that radiation affects the heart long term. These patients are greater at risk as well of stroke, heart attack, chest pain, and pericarditis. What's pericarditis? Well, the heart is surrounded by what we call pericardium. It's a sac that surrounds the heart. When you radiate anywhere near the heart, that pericardium becomes inflamed. And it may not cause a problem immediately. Some people get a big effusion or fluid around the heart, but for other people, it then, after the radiation goes away, but 20 years later comes to haunt you, and you have what's called constriction, where the heart is in this tight knit sac. It doesn't move. It's almost like a metal cast around the heart. Right now the heart squeezes and gives up. It squeezes and gets bigger. The heart is elastic, and the area around the heart's elastic. But can you imagine just putting that heart in a constricted metal cask? It can't open, it can't close. You go into heart failure. Management of risk factors is real important. Diabetes, high blood pressure, high cholesterol, weight, smoking, sleep apnea. All those things are so important to control. Now, for prostate cancer, when we give Lupron injections or androgen deprivation therapy, people lose weight. They have much more fat from this, because it turns out, I have to say, how to do this politically correctly, women tend to have a lot more fat in their body than men do. And when you give androgen deprivation therapy, estrogen sort of builds up some of the fat in men, and that happens as well. And there's insulin sensitivity. When you give something like Lupron, you lose your sensitivity to insulin, your blood sugar goes up, your triglycerides go up, your cholesterol goes up. And patients who receive androgen deprivation therapy have a 20% higher risk of heart disease and a higher risk of a heart attack over a 5-year period compared to those people who don't get the therapy. So when someone comes into me and says they're having prostate cancer and now they start having chest pain, I got to worry. And then I got to think to myself, okay, I got to think about how to treat this guy because most men don't die of prostate cancer. It's a long process. And I want to find a way to prolong their life as well without putting them through a lot of hell. So it's a process. What about childhood cancer? I told you that cardiovascular disease is the leading non-cancer contributor to early morbidity and mortality of survivors of childhood cancer. When I see a 25-year-old that has had Hodgkin's disease or a lymphoma or had gotten total body radiation, I'm worried about that kid because I've got to monitor that kid, that adult, a lot more closely than I do somebody who's had a normal childhood. So why for women? Why should women see a cardiologist? Well, I just told you that breast cancer is probably the most common cancer in women. And the way most oncologists start treating breast cancer is with drugs called anthracyclines. These are drugs like adriamycin, doxorubicin. You may have heard of these drugs. Some of you in this audience may have gotten these drugs. Mm-hmm. That affects the heart. We've known that for many years. And it's also in a dose-dependent way. What I mean is, once you've gone over 250 milligrams per meter squared, that's the cutoff point where the heart starts dysfunctioning. And this is irreversible. Women that get heart dysfunction from adriamycin or doxorubicin or any of the anthracyclines, it's not reversible. This is permanent damage. We used to diagnose this when I went to medical school and during my training with cardiac biopsies. But we're a little more sophisticated in how we diagnose this now. But it really is a dose-dependent kind of thing of how you follow this. Now, in this day and age of immunotherapy, we could say that breast cancer is estrogen positive or negative. It means it has receptors for that. It's progestin positive or negative. And there's this HER2, HER-2 antigen on breast cancer cells. And we have learned that people that are HER2 positive will respond to drugs such as Herceptin or trastuzumab. And there are some cousins of Herceptin as well. And so, but Herceptin is also a drug that now affects the heart and makes the heart weaker with time. The good thing about Herceptin compared to the anthracyclines in that first group is that if you stop Herceptin, I have a lot of breast cancer patients like this, we'll stop the treatment for a few months, the heart muscle gets better, we then start up maybe at a little bit of lower dose. And that's talking to the oncologist and coordinating that kind of stuff as well. There are platinum-based chemotherapies that cause neuropathy. There are microtubule inhibitors that cause rhythm disturbances like atrial fibrillation. There are anti-metabolites, 5-FU or Folfox, if anybody's got colon cancer in the audience. Folfox is a drug that we give for colon cancer, but I've got to watch those patients for heart disease. And if you start having chest pain on Folfox, you could be developing a blocked artery, and it's something to keep in mind. There are protease inhibitors like Velcade, which cause heart failure. People just all of a sudden go into heart failure. And I got to tell you, I have a review article in my hands here. And just to tell you the voluminous stuff that you have to read to keep up on this stuff. This article is just from June. I was going to count in anticipation of us how many drugs are mentioned here with cardiac side effects. And there must be 50 to 60 just in cancer chemotherapy alone in this article. And to be honest, I have to keep on my desk a list of drugs with side effects so that I remember it, because it's just literally impossible to do on a day-to-day basis. So the latest drugs that we have are immune checkpoint inhibitors. It turns out that a lot of these cancer cells, in order to survive, they use our immune system to survive. And they have these ways of avoiding surveillance, if you will. That's how cancers do. And by giving these drugs called immune checkpoint inhibitors, we turn off the antigen on the cancer cells that helps them avoid surveillance. And then the immune system kills the cancer. These immune checkpoint inhibitors are great. The problem is they also cause a lot of side effects. And we've had some deaths from these drugs as well. Myocarditis is one of them. I mean, it's rare, but this is where these immune checkpoint inhibitors not only allow the immune system to kill the cancer cells, but the immune system loses its ability to recognize self. In other words, my immune system likes me. It doesn't attack me. But if some foreign body comes into my system, it will attack that foreign body. When you give immune checkpoint inhibitors, it attacks the cancer cells, but it forgot who you are too, and it starts attacking you. And that happens in a few people. And so you can get myocarditis, you can get arrhythmias, that's the heart, but you can get GI problems where you have profound diarrhea, you can get terrible rashes. Almost every system of the body can be affected. And when that happens from these drugs, we have to recognize it, we have to stop the drug, we have to give high dose steroids, and it's a process, and some people get real sick and don't make it. So should all cancer patients have a cardiologist? That was one of the questions Wendy said somebody would ask me. And I think you ought to have a baseline exam. And I think that's fair. And not all cancer patients. Look, if you got skin cancer, I don't think you need a cardiologist. I think that if you have any chemotherapy or radiation therapy anywhere near the chest for your cancer, it is reasonable to at least get a baseline cardiac exam. Baseline. Now, for people with breast cancer that are taking Herceptin, they got to be monitored every couple months, and they got to have regular echoes, and they got to have, there are different monitoring systems, right? But for somebody with prostate cancer who's on hormone-reducing therapy, you get a baseline exam, and then we tell patients, look, if you have any symptoms, you call me, chest pain. I'll go over those symptoms in a little bit, but otherwise, you're okay, but just recognize your symptoms. And it's up to us to educate people and to make sure that they're aware of their symptoms. That's the most important thing. I always say that we can help people if we catch something early in the disease process. But if you stayed at home sick for a week and then you come in and your kidneys are failing and you're acidotic and your liver is failing, by then it's too late, right? So we got to catch these things early. So one of the things we need to do is look at the risk factors for heart disease. So I'll just go through them. Recently, guidelines were rewritten. When I went to medical school, normal blood pressure was 150/90. That really dates me. But today it's 120/80. And anything that's higher than that, we consider elevated. 120 to 130 is borderline, but 130 to 140 is stage 1 uncontrolled hypertension, and 140 above is stage 2 uncontrolled hypertension. And so I generally aim in my patients to get a blood pressure down to 120. Now, there are caveats to that, and that's why they call it the practice of medicine and not, otherwise, it's like a car. The Uber is going to have driverless cars soon. Anybody could do this. I've got patients that are older that if you give them a blood pressure drug, they pass out, right? Because as you get older, your blood vessels stiffen. So a blood pressure in an 80-year-old of 150, 160, 170 might be acceptable, whereas in a 20-year-old, it is not. So you have to always look at the entire patient and see what's going on. But blood pressure control is very important. And a lot of these chemotherapeutic drugs raise blood pressure. In fact, the patient I had with prostate cancer, I was telling you earlier, he's on a hormone altering drug and blood pressure can go up. Diabetes, a real problem. Obesity is a real problem in America. Being overweight means that your insulin that your body produces can't hit all the cells in your body. If your insulin can't hit all the cells in your body, your blood sugar is out of control. We measure the control of blood sugar by a test called the hemoglobin A1C. We measure that every 3 months because hemoglobin, which is on our red cells, is very sensitive to the levels of sugar in the blood. So if the level of sugar in the blood is 300 all the time, there are some chemical reactions that occur in the hemoglobin, and we can measure that in the lab. If the blood sugar is 100, which is normal, or less, we could also measure that. The higher the hemoglobin A1C level, that means that the hemoglobin's been altered by higher sugars, the more out of control your diabetes is. And the reason we wait every 3 months to check that test is every 120 days, your body regenerates the red cells, right? or 4 months. So we wait 4 months to check another hemoglobin A1C because you got a whole new set of red cells and a whole new set of cells that are exposed to your blood sugar. So that's why we don't check it more than every 4 months. Weight. I harp, if any of my patients are on the line, they're laughing now because I'm a pain in the ass. Because weight is so important in controlling your blood pressure, your blood sugar, your sleep apnea, your hypertension, everything. I mean, weight is so critical in doing that. And you know how we know what ideal body weight is? Patients once asked me that, and I really did the research to find out. It was New York Life that figured this out years ago, because New York Life figured out that if you want to insure somebody and you want to make money on the insurance premium, you want them to live a long time. And so they figured out that people that were overweight didn't live as long as people that were ideal weight. And really, these BMIs that are based on height and weight and ideal body weight comes from insurance companies. That's where the original work was done. It was all to make money. But we know that if your weight is down, all those metabolic processes do better. And what about sleep apnea? If you've got a spouse that stops breathing while they're sleeping, or snores, or I imitate this in my office where somebody's struggling to breathe and go, and they're trying to breathe and they can't do it, and then they go, they snort sort of. That's your body when you're sleeping trying to struggle to breathe. And if you're struggling to breathe like that, you've got sleep apnea. And yeah, I know the mask is not very sexy, but there are mouthpieces to keep the airway open. There are nasal CPAPs now. Sometimes people can have big tonsils, and all you have to do is, not at our age we want a tonsillectomy, but if you get those tonsils out of the way, you can then breathe better at night, then you sleep better. And when you have sleep apnea and you can't breathe, your body's struggling all night to breathe. That raises your blood pressure. That raises the pressure in your lungs. That causes swelling in your legs because now the pressures in the lungs are high. It's all a chain reaction. One follows the other. And so sleep apnea and addressing it is very critical. And then there's cholesterol. A lot of people come up to me and say, Doc, what do you take? Are there any medicines you take? I said, the one thing I've taken for about 25 or 30 years is a statin. My father had his first heart attack in his mid-40s. And I've always said, I say this to my wife every day, I don't know what tomorrow holds. You never know what tomorrow holds for any of us. But I do know that lowering cholesterol lowers your risk of heart attack. And that is extra true for the cancer patient. That's extra true for the smoker. There was a study done in the Air Force Base in Texas. This is a 1990 study, but it holds so true, where they took mostly men in this study, Air Force members, and they took smokers and non-smokers and gave them Mevacor, which was the first statin that came out, or lovastatin. And the people that smoked had a higher risk reduction of heart attacks than the people who didn't smoke. Well, that makes sense because they had a higher risk, right? This group here would have a 45% risk of a heart attack over 10 years. The non-smokers would have a risk of maybe a 20% over 10 years. So, of course, the risk reduction was greater in the smokers. So when I had somebody who smokes, I definitely push a statin on them because I may not be able to get you to quit smoking, but at least let me try to stave off a heart attack. And, a lot of people can't take statins because it causes muscle aches. That's the most common thing I see is muscle aches with statins. But we have new drugs out now, Repatha and Praluent, which I didn't mention here. These are injectables. And just like we have these new cancer immunotherapies, Repatha is a cool drug that causes increased destruction of cholesterol when you inject yourself, like insulin, twice a month. We have Zetia that inhibits the absorption of cholesterol in the GI tract. And we have fibrates and fish oils that lower triglycerides. And recently, the American College of Cardiology has come out with a nomogram on how to treat triglycerides because we were never sure whether triglycerides were really a cause of heart attacks or not. And now we're pretty sure that they are, and that they do play a role. And the smoking. And let me tell you, my guy who came in today, whose wife has cancer at home, who owns a company, who's had a heart attack, he took up some cigarettes again recently. He's just so stressed out. He really needs to see you, Wendy. I mean, he's so stressed out. And it's a problem. I mean, what am I going to tell this guy? He's dealing with, and he owns his own business. He said, you know, doc, nobody ever tells me attaboy when I do a good job. People only tell me when something goes wrong. And I deal with all the problems. And he's in the service industry. So he's dealing with that, with his home, with everything else. And all you can do sometimes is listen, right? I feel like that as a doctor sometimes too. We don't get the attaboys as much. We only know when something's going wrong. But it's true in most businesses, right? You probably hear stuff too in your business where you feel like maybe one of your patients didn't feel like, Wendy, that you treated them with enough kindness. I'm sure if you've practiced long enough, you've had that happen, as nice as you are. And you didn't know what you did wrong, right? And it happens. It happens. And you only remember those. You don't really remember the old attaboys that you get every day. So it's really important that whether you have cancer or whether you have heart disease, no matter what you have, you got to get into some good habits. And one of them is daily exercise. And I commend my wife. She walks like, 10,000 steps a day. And it's amazing. And it's truly a great habit to get into. I think in our lives, we sometimes have a rough time getting there because we work, we do other things, but it's really important to get your 20 to 30 minutes of exercise. Be compliant with your meds. I can't tell you how many people just, I missed a dose here, I missed a dose there, and then they come in with a stroke because they weren't taking their blood thinners. Take care of your head. Whether you do yoga or biofeedback or therapy, or if you need meds. And what disappoints me most about medicine today is the first thing we do is throw meds at a problem. Oh, you're depressed. Take Wellbutrin or take Zoloft. In fact, the patient I was telling you about that I keep referring to today was on Wellbutrin. That's what his PCP gave him, but didn't really recommend therapy or doing something else to try and work through the problems. Because at the end of the day, this guy has a real reason to be depressed. I'd be depressed if I was in that situation. It's how you deal with it and how you pick yourself up that matters. And you got to find a physician you can talk to and have confidence in. Find a collaborator and not a cowboy. I mean, there's some docs that you walk in and it's test after test after test, but they're not doing you any good. And find somebody that works with you and understands you. And you got to have an advocate. I am a big believer in this system that is so huge that you've got to have somebody out there that's fighting for you every day. And it can't be just you. I can tell you in no uncertain terms, and I am going to say this, and I feel guilty even about saying this. When I walk into a patient room and I see two family members there, I know I spend 5 extra minutes with that patient, whether it's because of the family members or what it is, or I just know I'm there a few more minutes, making sure that everybody understands everything. And I hope I give the same care to the two people, but I know I spend a few extra minutes when there's an advocate there for the patient. And that's so important because you know what? It keeps me honest. And you want to keep your doctor honest too. So have an advocate. And finally, things to watch out for. When you have cancer, and you also have to now worry, oh my God, this doctor's told me I got to worry about heart disease and diabetes. Know what to look for. If you've got chest discomfort, and not the little twinge that comes on for a second that goes away, that's not heart pain. But if you're walking up a flight of stairs every day with your basket of laundry or taking the garbage out, whatever you do, if you're walking up a flight of stairs every day and all of a sudden it's harder to do that, you're more short of breath. Or you get some tightness in your chest when you go out for a walk. That's something to keep in mind. You're getting an irregular heartbeat. Atrial fibrillation is very common in my cancer patients. And, I have to put people on blood thinners. I have to treat their arrhythmias. Some people will wind up needing a pacemaker, but you got to recognize that stuff, right? And swelling in the legs, inability to lie flat. If you get short of breath laying flat, that's a problem. And the most common thing, they say men are from Mars and women are from Venus. If you ever read that book, that dates me too, by the way, 1970s or 80s. Women complain about heart disease differently than men. women will say, I'm just tired, doc. I got a lot to do. And that could be the sign that they're having heart pain. Whereas men say, Mary, I'm having a big one, or they complain, they bitch, they moan, men are complainers. They say, this doesn't feel right when I go up a flight of stairs. Women don't, women have weird symptoms. And sometimes they don't have obvious symptoms. And so women are tough to figure out. I've said this my entire life. I mean, they just are tough to figure out. And you need to know when to take them seriously and when not. And they're not going to tell you I'm having chest pain. But fatigue and shortness of breath in women are very, very common. And so with that, I'm going to close. We have about, I guess, 8 or 9 minutes for questions. And I'm happy to take any questions, or if there's something I didn't cover, Wendy,